MCQ. You have to select the best answer. So mainly the kind of questions will be asked. Radiological anatomy. You have to identify the structure and number 2 is the gross abnormalities, like you have to make the diagnosis, the best diagnosis. And number 3, very easy about the investigation, like this is CT scan, MRI or ultrasound, these kind of things. And maybe you will ask like which investigation is better than that method of investigation. Like X-ray is better than CT, or what I showed you. I will tell you in my revision class. Yes. Okay. So we will start with imaging modalities. So the number 1 is chest X-ray. This is the most frequently done. And what is about this? CT scan. Sorry. And this is what? Ultrasound. What about this? Isotope. MRI. Very good. Angiography. Leading swallow examination. And then biopsy. So these 8 investigations we do to diagnose a patient with chest problems. The most frequently done investigation is chest X-ray. So if you find any abnormality, then we proceed to CT scan. Particularly if we are, I don't know, it's I think there is time. Just wait. Sorry. I don't know.
Okay. كيف تفضل تشوف بس كده بقى؟ عشان
ريزولوشن؟
ايوه
انت مرقم
عشان ما تضل ما بتيجي مظبوط. ايش هو؟ لا لا لا
all this investigation. Okay, now we will start with the chest X-ray. So you should know the normal radiological anatomy of chest X-ray. So I told you what is this structure? Trachea. This aortic arch. This one?
pericardium.
Pulmonary artery. And what about this? Left ventricle. What about this? Right ventricle. Okay, and this one is? Superior ventricle, right. And these are what? Diaphragm. And what about these? Good. And what about this? Scapula. And these are, of course, lung fields. Okay, this one is axial scan done through this level, and you should know what this structure is. Very good. What about this?
Superior vena cava.
Inferior or superior?
Superior vena cava.
Superior vena cava. Okay, these are, and what is about this?
Sternum.
Sternum and
Vertebrae.
the sternum. Slightly lower level. Axial scan, and this is what CT scan, and this CT scan is done with which window? Lung window or mediastinal window? This is mediastinal window because we see the mediastinal structures. We are unable to see the lung fields, so this is mediastinal window. Anyway, this is what? Very good. This is aorta, and this is ascending aorta. And what about this? Descending aorta. This is what?
Left, right ventricle.
No. This is approximately at this level. So this is pulmonary trunk, main pulmonary trunk. right pulmonary artery, and what about this? Left pulmonary artery. And what is this vein structure? Very good. So we have a camera. And what about these two?
Break is what?
This is left main bronchus and this one is right main bronchus. Okay. And posterior to bronchus, what is this structure?
Descending aorta. Descending aorta.
Esophagus. Okay. So these are the main structures. I will repeat: ascending aorta, descending aorta, main pulmonary trunk, right pulmonary artery, left pulmonary artery, and here is the left main bronchus, right main bronchus, aorta. This one is spine, and these structures are what? What are these? Scapula. And this is at this level, axial scapula, and this level. So what is this? Yes, this is liver and dome of diaphragm over here. Part of liver and dome of diaphragm has come here. And what about this? Very right ventricle. Posterior to right ventricle is left ventricle. What is this? Very good. Here is the inferior vena cava, it is seen here. And this is what? Very good. Same descending aorta. So this is arch, descending aorta, and again descending. Okay. And both are, these are lungs. We are unable to see the lung because this is mediastinal. Okay, what window is this? Very good. Again, this is CT of the chest, and this is lung window. Okay, we are unable to see here the mediastinal structures. So in lung window, I told you the size of what is this disc? Notice. Yes. This is pulmonary artery, branch of pulmonary artery, and adjacent to this pulmonary artery, this rounded is what? Bronchial tree. So the size of bronchial tree should be equal or less than pulmonary artery. If this bronchus is more than pulmonary artery, the condition is called bronchiectasis. This is the rule of thumb. This bronchus diameter should be equal or less than bronchial artery. If it is more than bronchial artery, then the condition is called bronchiectasis. So this is CT of the lung. And one more thing I told you, you should not be able to see line shadows in the outer 1 centimeter of the lung fields. If you see the line shadow, then the diagnosis is interstitial lung disease. Remember these 2 points. What about this? That if both are CT, but this is mediastinal window and this is lung window. So in mediastinal window, you are unable to see the lung field, and in lung window, you are unable to see clearly the mediastinal. So we can manipulate the CT scan. Okay. What is this? Descending aorta. What about this? This way. No. This is right atrium is anteriorly and on right side. Right ventricle is anteriorly and left side. Left ventricle is on left side and slightly posterior. And behind all these structure is left atrium. And these are the pulmonary veins entering into the left atrium. Okay, this is descending aorta, esophagus. What about this? This is main pulmonary trunk, this is right pulmonary artery, and here is the left pulmonary artery. This is ascending aorta, and this one is descending aorta. This rounded black structure is esophagus, and in front of esophagus is left main bronchus and right main bronchus. Okay, we come to abnormalities. What is the abnormality seen here? Now tell me, what is your diagnosis? If you are shown this kind of slide, what is this? No, not tracheal chip. This is ultrasound. This one is diaphragm, this is part of liver, and what is this? Pleural effusion, the most frequently seen abnormality in the hospital. Lot of patients with pleural effusion we see. Okay, if you see blunting of CT angle, and if you do ultrasound and you see this kind of picture, this is highly suggestive of pleural effusion. Yes? No, there is blunting like this. If you see, this is blunting. If you go back, sorry. Okay, I will show you another X-ray clear. So, this is another patient. What is your diagnosis? Again, pleural effusion. And what is the cause of pleural effusion? Cardiac failure. There is cardiomegaly with pleural effusion. Most likely cause of pleural effusion is problem in the heart, because the heart is involved. So there is blunting of CT angle here. This CT angle is clear. Yes. What is this condition? Lung collapse. Anyone else? No. Yes, pneumothorax. And if we see fluid also and air also, what is the condition? Hydropneumothorax. This is hydropneumothorax. This is air fluid level. So this is typical appearances of hydropneumothorax. It means there is fluid and air inside the pleural cavity. So this is hydropneumothorax. This is pleural effusion. Fluid will appear white and air will appear black. Remember this thing. Okay. So if we see in the pleura both fluid and air, the condition is called hydropneumothorax. Hydro means fluid, pneumo means air. So hydropneumothorax inside the pleural cavity. There is air also and fluid also inside the pleural cavity. This is pleural effusion with cardiomegaly. Yes, what is this? Very good. So there is collapse of lung and there is air inside the pleural cavity and there is some midline shift of the mediastinum. So the condition is called tension pneumothorax. This is very important. You should be able to recognize these kind of X-ray. If you don't recognize these X-ray, you will become a dangerous kind of doctor. So this is kind of emergency, surgical and medical emergency. You can save the life of a patient if you recognize this, because these patients, they require urgent treatment. You have to remove this. Otherwise there will be cardiac and renal. Okay, what do you think about this? There is increased density and air bronchogram, these nuisances inside. Pneumonia or consolidation, both will be correct. This is right lobe pneumonia or consolidation. Only pneumonia means there is infection, but consolidation can be due to infection or neoplastic process or fluid inside. It is a non-specific term. If you write pneumonia, it will also be correct. If you write consolidation, it will also be correct. Yes. What is that abnormality?
Hepatomegaly?
No, there is no pleural effusion. This is the abnormality. There is tracheal shaft and paratracheal density. So what is the number one diagnosis?
Neoplasm.
Enlarged thyroid. This is the number one diagnosis. And if you want to know more differential diagnosis, it can be due to lymphadenopathy. But lymph node does not cause shift of the trachea. Usually the trachea is in the center if there is lymphadenopathy. If there is a large retrosternal thyroid, it will cause like this shift of the trachea. So this is a large thyroid. Yes. Spot diagnosis. Cardiomegaly. Okay. Just cardiomegaly is sufficient. The heart size should be less than half of the diameter of the chest. If it is more than the half of the diameter of the chest, there is cardiomegaly. Yes. Collapse. Anyone else?
Pneumothorax.
Pneumothorax.
Go to the previous slide.
You want to see the previous slide? Yes. No, this is not a dextrocardia. Left ventricle is on left side.
But the sign of
I have not noticed this thing. But sometime I tell you one more thing. Sometime they put the marker. We need to repeat again. But just concentrate on this now. Okay. Yes, if the heart is enlarged, okay, more than half centimeter. Okay, if this is dextrocardia, then this stomach is, you can see here, stomach is in normal position also. Just don't get confused with that. Okay. What about this?
Hydropneumothorax.
No. There is raised hemidiaphragm. Right hemidiaphragm is raised. I told you the difference between the two diaphragms should not be more than 3 centimeter. Okay. So it is more than 3 centimeter. If the diaphragm is raised, one diaphragm is raised, we say you need lateral elevated hemidiaphragm. There are many causes. Just remember one or two causes. What are the causes above the diaphragm? It can be pleural effusion, collapse, or phrenic nerve palsy. This is above the diaphragm. Inside the diaphragm, two important causes: eventration, if you remember, and trauma. And what about below the diaphragm? Yes, hepatomegaly, hepatic neoplasm, abscess, anything below the diaphragm. Subphrenic correction also can cause raised hemidiaphragm. Yes, again, what is your diagnosis? Again, there is left hemidiaphragm is raised. And what is the cause of raised hemidiaphragm here? This is the CT of the same patient. What is this? This one is stomach. Stomach has gone inside the thorax, and this patient has history of trauma. So what is your diagnosis? Yes, traumatic rupture of diaphragm. So again, if there is trauma, you will see like this. Yes. Very good. Bilateral hilar enlargement. What are the causes, important causes? Sarcoidosis, lymphoma. These are the two important causes. And one is vascular cause also. Pulmonary artery hypertension can cause also enlargement of the hilar, but with enlargement the heart should also be enlarged. So this is not pulmonary artery hypertension, this is a hilar sarcoidosis, lymphoma, sometimes metastasis can also cause this kind of appearances. So if you write bilateral hilar enlargement, this will also be correct. Yes? Yes? Diagnosis just bilateral hilar enlargement. There are many causes of hilar enlargement. If you write hilar enlargement, it will be correct. If you write lymphoma, it will be correct. If you write sarcoidosis, it will be correct. Because all of them give similar kind of appearances on X-ray. Clinically, you have to differentiate these structures, these diagnoses.
Doctor.
Okay. Again, here there are bilateral hilar enlargement. But with hilar enlargement, the heart is also enlarged. And these are sternotomy sutures. And these are where replaced aortic and I think pulmonary valves are replaced. So what is the diagnosis here? Hilar enlargement. Pulmonary artery hypertension.
Doctor.
Yes.
In exam, should I write the sign I see or diagnosis?
Just diagnosis, you just see the questions and make the best answer. All the diagnosis will be given. Okay, what is your diagnosis here? No cardiomechanic. No fracture. This is collapse of right upper lobe. You see there is loss of volume here. The diaphragm is also raised, the hilum is also raised, and trachea is also shifted towards this side. Yes. So this is collapse of right upper lobe. And I told you and I will tell you again, if you see collapse above 50 years of patient, recent collapse, always rule out for malignancy. The most important cause of collapse in adult patient is malignancy, bronchogenic carcinoma. Bronchogenic carcinoma. Bronchial tumor, it is bronchial tumor. Inside the bronchial tree, it is called bronchogenic carcinoma. Lungs. Yes, what is this? Yes, complete lung collapse. All trachea shifted, there is crowding of the ribs, we cannot see the heart margins. All heart is shifted towards collapse. So the most important cause of complete lung collapse again is carcinoma and other pneumonectomy. In post-operative cases, then pneumonectomy is the other ones. So this is upper lobe collapse, this is right lung collapse. Yes, again, not to miss the diagnosis. Like tension pneumothorax, you should not miss this diagnosis. If you miss the diagnosis, the patient may die within 24 hours. Very good. Subdiaphragmatic air or subphrenic air. And this is called what? Pneumoperitoneum. Pneumoperitoneum. Up to 90% of the patient with acute abdomen, they required surgery within 24 hours. Because the most common cause or important cause of pneumoperitoneum is what? Perforation of the gut, usually the duodenum. So you should be able to recognize this sign. Yes, difficult X-ray. Here you can see the diaphragm clearly. Here you cannot see the diaphragm. The hilum, usually I told you the left hilum is higher than the right one. The left hilum is downwards and there is increased retrocardiac density. Now tell me the diagnosis. This is typical appearances of abnormality. So this is left lower lobe collapse like this, and this is very easily missed. So always see the diaphragm. If the diaphragm is not clearly visualized and if there is increased density behind the heart and the hilum is pulled downward, always think of collapse. Again, in the most common cause of collapse is malignancy. So this is left lower lobe collapse. Yes. What is your diagnosis? Very good. This is tension ecothorax in another patient. What about this? This is collapse, consolidation or something else. This is opaque hemithorax with medius sternal shift to other side. So most important cause is pleural effusion, massive pleural effusion. And here again opaque hemithorax with medius sternal shift towards this side. Then the most important cause here is collapse. So remember, these both are opaque hemithorax. Here the mediastinum is shifted towards left and here the mediastinum is shifted towards right.
What's the diagnosis?
Okay. So here the diagnosis is collapse. Here the diagnosis is massive pleural effusion. Yes. Emphysema. Anyone else? Yes, what is your diagnosis? Very important X-ray. Mastectomy. So, right mastectomy. Due to mastectomy, this starts appear. Always see the breast schedules. Lot of patient, I told you, number 2 cause of death in females are breast carcinoma, and lot of patient in hospital you will see with mastectomy. Well, it is not flat, it is, I will show you flat diagram. Anyway, this is mastectomy, this is not emphysema. Emphysema is more flat. Yes. What is your diagnosis? Problem is on right side or left side? Okay, you can see the ribs here. Here you can see the ribs. This rib you cannot see. And also this hilum is larger than the right one, and this is more bigger than the right one. So there is rib destruction with hilar enlargement. So most likely this is kind of malignant process. What malignant process I don't know. We have to do the biopsy and see. Either this is metastatic disease or primary lung carcinoma. But on X-ray you can tell, okay, there is hilar enlargement and rib destruction. Yes, but now tell me, what is your diagnosis? This is flattening of the diaphragm, tubular shaped heart, and more craniocordial diameter of the chest. Superior, inferior diameter or distance is increased. There is flattening of the diaphragm, tubular shaped heart, and decreased density of the lung fields. And if we do CT, and we see multiple lucent or distended air spaces, these crack. So what is your diagnosis? Emphysema. So this is typical appearances of emphysema. What is this? Very good. This one, descending. This one, superior vena cava. This one, trachea. So this is typical appearances of emphysema. Yes. What is your diagnosis? Yes, fibrosis. If you see line shadow at the periphery, distortion of the parenchyma, and reticulonodular shedding on the X-ray with reduced lung volume, the diaphragm is raised compared to normal one. The diagnosis is what? Interstitial lung disease. Again, I told you there are many causes of interstitial lung disease, maybe 100 causes. So on plain X-ray and CT, it is very difficult to differentiate this. Clinical correlation is very important.
What is the diagnosis?
Interstitial lung disease. Just interstitial lung disease at your stage is sufficient. Yes, if you see tubular and cystic shadows in the lung, and if you do CT scan and you see this cystic dilatation of the bronchiectasis like this. So what is your diagnosis? Bronchiectasis. This is typical appearances of bronchiectasis, dilatation of bronchiectasis. And I told you this is the bronchiectasis and this is the pulmonary artery vessel. So it is more than the vessel size. If it is more than the vessel size, then this is diagnostic of bronchiectasis. Again, there are many causes of bronchiectasis. So for you to remember only bronchiectasis. What are the causes? Okay, hemoglobin deficit. The cystic bronchiectasis. One is cystic fibrosis, yes. Cardiac nerve syndrome, this is congenital. And repeated aspiration can also cause bronchiectasis. Infection can also cause bronchiectasis. And even if there is a tumor compressing the bronchus, it will also cause bronchiectasis due to repeated infection of bronchiectasis. Yes. If you see like this multiple rounded densities, big densities.
Malignancy.
What kind of metastasis? Typical appearances of metastasis. If you see multiple rounded densities in both lung fields, always think of metastasis. Yes, what is your diagnosis? This is another patient with thyroid enlargement. There is a flaky shift with increased density. Enlarged thyroid. This one is trachea. Trachea should be in the center. It is shifted towards the right and there is increased density here. So this is enlarged thyroid. Okay. Very good. There is loss of volume and increased density here. This is collapse. And I did biopsy of this lung and it turned out to be malignant. Yes?
Large hilum.
Here, bilateral hilar enlargement also seen along with paratracheal enlargement. So if you see lymph node in the paratracheal region also and hilar region also, then number one differential diagnosis is lymphoma. If you see bilateral hilar enlargement only in a young female patient, then it's our diagnosis. This is bilateral hilar enlargement along with paratracheal enlargement of the lymph nodes. Bilateral hilar and right paratracheal lymphadenopathies. Hilar and paratracheal lymph node enlargement, most common cause is lymphoma. So we come to mammography, one lecture mammography also I showed you. So this is normal breast. And what is this? Normal anatomy, what is this? This is axillary fold. What are these? No, these are normal lymph nodes. Normal lymph nodes are seen very frequently in the breast and they are usually less than 1 centimeter and they contain central lucency due to fat inside. If they become dense, more than 1 centimeter, they are usually abnormal. This one is axillary fold. This is what? This is glandular tissue. Glands appear white like this. And these lines are what? Trabecular lines. If there is a tumor, they become thicker. Similarly, this is skin. It should not be more than 3 millimeters. Sorry. If it is more than 1 millimeter, it means the skin is thickened. So this is the normal anatomy, axillary fold, lymph node, skin. This is glandular tissue. These are the trabecules. Yes, this is benign or malignant?
Benign.
One is saying benign, one is saying malignant. Why this is malignant? Very good. Because this is ill-defined. Second thing, there is some skin thickening. Third thing, there is skin retraction also. The skin is retracted. It should be normally like this, but it is retracted towards the tumor. Ill-defined nasty with skin thickening and retraction. This is highly specific for malignancy. This is benign or malignant? So again, here you can see the thickening and some retraction of the skin and a large ill-defined mass, and this you can see distortion and thickening of the trabeculae. These are thickened. So again, this is a malignant mass. For you to remember, only malignant mass. If you are shown this or this is malignant mass. So again, this is mammogram with diffuse thickening of the skin. The two important causes of diffuse thickening of the skin are either malignancy or infection, mastitis in one breast. If you see both breasts with diffuse thickening of the skin, then you should think of any cause of skin edema like renal failure, cardiac failure, hepatic failure. If both breasts show diffuse thickening, if one breast is showing diffuse thickening, think of infection or neoplasm, and clinically very easily you can differentiate this. You remember I told you about the calcification? Yes, if you see microcalcification like this, and they are of different size and different shapes, and their size is less than 0.05 millimeter, they are called microcalcification, and they are highly suggestive of malignancy. And I tell you, up to 20 to 30% of the patient, they won't have any mass, any complaint, only this microcalcification we see, and we make the diagnosis. So this microcalcification is only seen on mammogram. They are not seen by MRI, by ultrasound or CT scan. Only MRI, mammogram can diagnose these microcalcification. And these are macrocalcification, big calcification. Macrocalcification. This is benign or malignant? Benign. Most likely this is benign. This is well-defined mass with big calcification. Yes. What about this?
Malignant.
Again, it can be benign or malignant. And if we do ultrasound and we see this kind of thing.
Benign.
So what is this benign what?
Defined, because it's defined.
This is cyst or fibroadenoma or what?
Cyst.
No, this is not fibroid. If you see on ultrasound black shadow and posterior acoustic enhancement, this is most likely cyst. Cyst and fibroadenoma will appear same on mammogram. So this was the last X-ray. So any question you want to ask?
Yeah.